We are today going to discuss on immunomodulators. What does immunomodulators term suggest? Anyone? Immunomodulators basically is a combination of two words, immunity and modulators. Basically by immunomodulators we mean the drugs that are modulating the immunity. So it can modulate the immunity by either suppressing it or enhancing it. So the drugs which suppress the immunity are called immunosuppressants, and the drugs which enhance it are called basically immunoenhancers. So the immunology, by immunology we mean the branch of science that is dealing with immunity. That means discrimination between the self protein and the non-self proteins. What can be the non-self proteins are? The non-self proteins are basically invading microorganisms or the transplanted organ, or it can be even an endogenous cell that can be mistaken as a foreign body. When the endogenous cell is being mistaken for foreign body, autoimmune disease results. Now, what are the types of immune response? A bit of physiology here. Immune response can be natural or called innate immunity, and it can be acquired or called basically adaptive immunity. Now, by innate immunity basically we mean these are present since birth. There is no involvement of the memory cells. It lacks specificity and uses only pre-existing but limited set of components and receptors to combat the invading pathogens. By adaptive or acquired immunity we basically mean these are adapted after birth. Here memory cells are generated after the first exposure, and on subsequent exposure there is heightening of the response to the invading pathogens. Now, what are the types of adaptive immunity? It can be humoral immunity where B cells, B lymphocytes take part, or it can be cellular immunity where T lymphocytes, cytotoxic T lymphocytes take part. Now coming to the humoral immunity, basically here antigen they enters the body, they are being processed by the CD4 plus T helper cells, by the macrophage or other antigen processing cells complex with MSC2, class 2 major histocompatibility complex. Then the antigen presenting cells complex with the antigen, they bind to the CD4 helper T cells. CD4 helper T cells again is activated by interleukin 1, and after activation and binding to the processed antigen, CD4 T helper cells they proliferate and secrete cytokines that include IL-2 and other interleukins, interferons and others. This in turn promote proliferation and differentiation of antigen activated B cells. The B lymphocytes they differentiate into the plasma cells and they start secreting antibody which bind to the antigen and lyse them. Antibodies finally bind and inactivate the antigen. Coming to the cellular immunity, here the cytotoxic T lymphocytes take part. The antigen is being processed by the macrophage and other antigen processing cells. Then in turn they basically the CD4 they basically bind to the CD4 plus T helper cells, which in turn secrete cytokines, particularly IL-2, to stimulate proliferation and maturation of the cytotoxic T lymphocytes, which when activated they lyse the antigens. Now coming to immunomodulators, these are drugs that modulate the immunity. They can be immunosuppressants, they can be immunostimulants. Now what are immunosuppressants? These are drugs that suppress the immunity. Where can we find, what are the uses of immunosuppressants? Number one, in case of organ transplantation, where the immunity of the person has to be suppressed to accept the foreign graft. And number two, in case of autoimmunity, where the body is unable to recognize these self proteins. Now, the immunosuppressants, they include calcineurin inhibitor, that include basically cyclosporine and tacrolimus. mTOR inhibitors, they include Sirolimus Everolimus. Then antiproliferative drugs that include Azathioprine, Methotrexate, Cyclophosphamide Chlorambucil and Mycophenolate Mofetil (MMF). Glucocorticoids including prednisolone and others, and a number of biological agents that include TNF alpha inhibitors, infliximab, etanercept, adalimumab, IL-1 receptor antagonist, anakinra, IL-2RA, that include daclizumab, basiliximab, anti-CD3 antibody, muromonab, CD3, polyclonal antibodies, anti-thymocyte antibody, Rho-D immunoglobulin. These are immunosuppressants. Now, coming to the cyclosporine. Cyclosporine is one of the most effective immunosuppressants. They are calcineurin inhibitors. They suppress cell-mediated immunity and are used and has vastly increased the success of organ transplantation. They inhibit T lymphocyte proliferation, IL-2, interleukin 2 and other cytokine production, as well as response of inducer T cells to the interleukin 1. Lymphocytes are arrested in G0 and G1 phase. Now, how does it act? Before knowing the mechanism of action of cyclosporine, let us know how the T cell, CD4 plus T cell is activated after being combined with the processed antigen. When the processed antigen binds to the CD4 plus helper T cells, what happens? It activates a number of signaling pathway. The CD4 plus T, after binding to T cell receptor, the T cell receptor, they activate the phospholipase C. Phospholipase C activate hole ki hobe? Phospholipase C activate korle ki korbe? GQ receptor pathway. General pharmacology. Phospholipase C activation will lead to hydrolysis of PIP2. PIP2 into IP3 and DAG, diacylglycerol and IP3. Now, DAG will mediate its action by phosphorylating protein kinase C and MAP dependent kinase pathway. While this IP3, they causes intracellular release of calcium. Now, this calcium, it binds to calmodulin and then they basically activate the calcineurin. It is a membrane bound serine threonine kinase. Now, this calcineurin, they basically dephosphorylate NFAT, nuclear factor of activated T cells. Now, being dephosphorylated, it gets activated, it translocates to the nucleus and is responsible for transcription of cytokine genes that lead to the generation of interleukins, interferons, TNF alpha and others. Now, this cyclosporine, basically it inhibits calcineurin. It is, first of all, cyclosporine get access to the host cell, CD4 plus T cell, and then they bind to an immunophilin, cyclophilin. Immunophilin class of protein called cyclophilin. After combining with cyclophilin, this cyclosporine inhibit the calcineurin and thus inhibit the subsequent steps of T cell activation. This is how the cyclosporine is acting. So, cyclosporine enters the target cells, bind to the cyclophilin and immunophilin class of protein. This complex then bind to and inactivates calcineurin, response of the helper T cell to antigenic stimulation phase. So, it is not able to activate the NFAT and cytokine genes are not transcribed. Cyclosporine also enhances the expression of TGF beta, transforming growth factor beta, and an inhibitor of interleukin 2 which attenuates or decreases the IL-2 mediated T cell proliferation and production of killer lymphocytes. Now, this drug is most active when given before the antigen exposure, although it can suppress the response of primed helper T cells and can be used even in autoimmune disease. Now, they selectively suppress cell mediated immunity. Why? Because they have got no action on the B lymphocytes and prevents graft rejection, and they have got little effect on the bone marrow suppression, on the bone marrow and reticuloendothelial system. Humoral system is not affected. The most important complication of cyclosporine is nephrotoxicity, and it also impairs the liver function. Also, other adverse effects are hypertension, the sustained rise in blood pressure, precipitation of diabetes, hirsutism, anorexia, lethargy, hyperkalemia, hyperuricemia, and opportunistic infection, gum hyperplasia, tremor, seizures. What other drug can cause gum hyperplasia other than cyclosporine? Gum hyperplasia. In the anti-epileptic chapter, it's phenytoin sodium. So, hirsutism, gum hyperplasia, tremors and seizures. Now, it is most effective drug in organ transplantation for the prevention and treatment of graft rejection reaction. It is routinely used in renal transplant, in the hepatic transplant, cardiac transplant, bone marrow transplant and other transplantations. Blood levels has to be monitored during its use to adjust its dose. Now, it is metabolized in liver by CYP3A4 enzyme. Now, it can also be used as a second line drug in autoimmune disease, like in case of severe rheumatoid arthritis, uveitis, bronchial asthma, inflammatory bowel disease, dermatomyositis. It has got some role in aplastic anemia too, where it is utilized in lower doses so that toxicity is also lower, but it does not cure the disease and has to be, and the disease recurs when the drug is stopped. Now, coming to the drug interaction, as it is nephrotoxic, it basically the drug interaction with other nephrotoxic drugs like aminoglycosides, vancomycin and others. Again, as it is nephrotoxic, it depresses the renal excretion of other drugs too, and then as it is metabolized by CYP3A4 enzyme, the enzyme inducers like rifampicin and phenytoin, phenobarbital, they lower its blood level and decreases the efficacy of the drug. Enzyme inhibitors like ketoconazole, like erythromycin, they increase the blood level and causes toxicity of the drug. Potassium supplements and potassium sparing diuretics when co-administered can cause severe hyperkalemia. So, how does cyclosporine act? Cyclosporine কিভাবে কাজ করে? It is a calcineurin inhibitor. Okay. Now, important side effect, nephrotoxicity. Now, coming to tacrolimus. Tacrolimus has got different chemical structure, but the mechanism of action is almost similar and is 100 times more potent than cyclosporine. Now, what is the difference in the mechanism of action? What was cyclosporine doing? It was going inside the CD4 plus T cells, binding to cyclophilin. It was an immunophilin class of protein. Now, instead of binding to the cyclophilin, it binds to FK506 binding protein, FKBP, and subsequently the steps are same. It is inhibiting calcineurin so that maturation and differentiation of T cell does not occur. It can be administered orally as well as by intravenous infusion. Like that of cyclosporine, it is also metabolized by CYP3A4 and the therapeutic application, the efficacy, the side effect profile are almost similar. It also requires blood level monitoring like that of the cyclosporine, but because of higher potency and easier method to monitor the blood level, it is generally now being replaced by cyclosporine. Tacrolimus is useful in patients of graft rejection which is not suppressed by the cyclosporine. It is particularly useful in liver transplant patient because it is not dependent on bile for its bioavailability. Being more potent, it is suitable for suppressing acute rejection that has set in, unlike that of cyclosporine. It can also be used in fistulating Crohn's disease. Again, hypertension, hirsutism, gum hyperplasia, hyperuricemia are less marked than cyclosporine, but tacrolimus is more likely to precipitate diabetes, cause neurotoxicity, alopecia and diarrhea. Dose limiting toxicity is renal. It is also nephrotoxic. Coming to the sirolimus. So, we here end calcineurin inhibitors, that is cyclosporine, tacrolimus. Now, we move on to mTOR inhibitor, that includes sirolimus and everolimus. Now, this sirolimus basically is a macrolide antibiotic. Can you name some macrolide antibiotic? Macrolide antibiotic like azithromycin, okay, like roxithromycin, clarithromycin. So, it is also a macrolide antibiotic. Tacrolimus is also a macrolide antibiotic. Now, initially when it was developed, it was named Rapamycin, but later it was seen that it has got a potent immunosuppressant action and it has been renamed as Sirolimus. Now, how does it act? Mechanism of action. Now, like tacrolimus, it binds to FKBP, that is FK506 binding protein after entering the host cell, CD4 plus T helper cell. Now, after binding, instead of inhibiting calcineurin, now basically it inhibits mammalian target of rapamycin, mTOR. So, it is not calcineurin inhibitor, it is mTOR inhibitor. Like tacrolimus, it is binding to the FKBP, FK506 binding protein, but subsequently it is not inhibiting calcineurin, it is inhibiting mTOR, mammalian target of rapamycin. Subsequently, it does, and hence it does not interact with calcineurin. This mTOR is an important link in the cascade of signaling pathway which lead to the differentiation and maturation of T cells activated by IL-2 and other cytokines. So, sirolimus alters or arrests the immune response at a later stage than cyclosporine. Now, like cyclosporine and tacrolimus, it is again metabolized by CYP3A4. Inhibitors and inducers of CYP3A4 significantly affect the level of sirolimus. The drug levels of sirolimus is also to be measured. Cyclosporine shares the same isoenzyme and raises the blood level of sirolimus. Now, uses, it is used for the prophylaxis and the therapy of graft rejection reaction. It can be given as a monotherapy, but it generally combined with either cyclosporine with or without glucocorticoid in graft rejection reactions, or it can be combined with basically mycophenolate mofetil with or without glucocorticoids. The patients who have developed renal toxicity to cyclosporine, there we avoid the cyclosporine combinations and there we prefer mycophenolate mofetil with sirolimus and with basically corticosteroids. Sirolimus is effective also in steroid refractory cases, and it is not recommended for liver transplant patient Now, drug-eluting stents are being used in patients of acute myocardial infarction. Now, this the drug here can be used as Sirolimus can be used as a drug in the drug-eluting stents. What does it cause? It inhibits the endothelial proliferation within the stent so that re-stenosis does not occur. Now, it is not nephrotoxic, but it can suppress bone marrow and mainly causes thrombocytopenia. Rise in serum lipid is common, also diarrhea, liver damage and pneumonitis are other adverse effects. Now coming to antiproliferative drugs, these are cytotoxic drugs that are used in cancer chemotherapy, but it has been found they possess significant immunosuppressant action by preventing clonal expansion of T and B lymphocytes. Now coming to Azathioprine, it is a purine antimetabolite, it is a prodrug, it is converted in the body to 6-mercaptopurine and thus it inhibits de novo synthesis of purine and thus causing damage to the DNA. It selectively affects the differentiation and function of T cells and inhibit the cytotoxic T lymphocytes. Cell mediated immunity is suppressed. The most important application is prevention of renal and other graft rejections, but it is less effective than cyclosporine and in patients who have developed nephrotoxicity to cyclosporine, there azathioprine can find a role. It can also be used in progressive rheumatoid arthritis and for maintaining remission in the inflammatory bowel disease. It may be used as an alternative to long-term steroid in some other autoimmune disease as well. Coming to Methotrexate, it is an antifolate, basically it is a folate antagonist. It has got a potent immunosuppressant action and anti-inflammatory action as well. Now, it is a first line drug in many autoimmune diseases like rapidly progressing rheumatoid arthritis. It is a drug of choice. Severe psoriasis, pemphigus, myasthenia gravis, uveitis, chronic active hepatitis. Low dose methotrexate maintenance therapy is well tolerated by many of the patients. Cyclophosphamide. Cyclophosphamide basically is a cytotoxic drug that has got more marked effect on the B cells and humoral immunity. It is used particularly in bone marrow transplant patients in which a short course of high dose is given. In other organ transplantation, it is kept as a reserve drug. Now, it can be rarely used in rheumatoid arthritis when systemic manifestations are severe. It can also be used in low doses for maintenance therapy in pemphigus, systemic lupus erythematosus and ITP. The most important side effect of cyclophosphamide, it's hemorrhagic cystitis. How we manage it? By use of Mishna. Chlorambucil, it is a weak immunosuppressant and can be utilized in autoimmune disease and transplant maintenance regimen, but not commonly used. Mycophenolate Mofetil is relatively newer immunosuppressant. It is a prodrug of mycophenolic acid which selectively inhibit inosine monophosphate dehydrogenase and thus it's an enzyme essential for de novo synthesis of guanosine nucleotide in the T and B cells, lymphocyte proliferation, antibody production and the cell mediated immunity are inhibited. Now, it is particularly used in renal transplant patient where a combination of cyclophosphamide, cyclosporine, glucocorticoid can be combined with mycophenolate mofetil. In patients who have developed renal toxicity, their cyclosporine can be replaced by Sirolimus. and then vomiting, diarrhea, leukopenia, predisposition to cytomegalovirus infection, GI bleeds are some of the important side effects of the Mycophenolate Mofetil. Mycophenolate Mofetil is a prodrug that is converted in the body to mycophenolic acid and then it do its subsequent actions. Glucocorticoid has got prominent immunosuppressant action and also is a potent anti-inflammatory drug. They inhibit the immune system at various steps. They inhibit the MSC expression. They inhibit the activation or proliferation of T lymphocytes. Expression of several interleukin and other cytokine genes are regulated by corticosteroids. And again, production of adhesion molecule is also depressed. With the use of corticosteroid drug, there is a rapid lymphopenic action. Means with the use of drugs, the patient develop lymphopenia. Why does it occur? Because of sequestration of the lymphocytes in the tissues. They have got marked effect on the cell mediated immunity, but no effect on the humoral immunity. Now, they can be used as a companion drug to cyclosporine and other immunosuppressant in various organ transplantations. In acute rejection, it can be used in high dose intravenously. It also find use in practically all cases of severe autoimmune disease, particularly during exacerbation period. Long-term corticosteroid use is generally linked to several complications and is better to be avoided and replaced by other immunosuppressants. So, name some calcineurin inhibitors. Calcineurin inhibitors. জোরে cyclosporine আর কি আছে Tacrolimus. Cyclosporine complication important side effect কি nephrotoxicity. Good. কোথায় ইউজ করা যেতে পারে? All immunosuppressant can be used for organ transplantation or in autoimmune disease. So, it has got used in organ transplantation, cyclosporine, in various organ transplant like heart, lung, bone marrow and others. And it is also used in autoimmune diseases like rheumatoid arthritis and others as a second line therapy. ঠিক আছে, নেক্সট ক্লাসে আমরা বায়োলজিক্যাল এজেন্টস নিয়ে পড়ব and immunostimulants.